Hello, and welcome to the Med-Surg-Nursing Journal podcast series. This series provides extended content relating to articles published in the journal, such as author interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off 1- and 2-year subscriptions to Med-Surg-Nursing, the official journal of the Academy of Medical Surgical Nurses. Simply visit medsurg-nursing.net, click subscribe, and enter promo code MSJSAVE50 to take advantage of this special discount. The nursing workforce has faced a staffing shortage since the early 2000s, with nurses leaving the profession due to retirement, burnout, or pay. This staffing shortage has been compounded by the COVID-19 pandemic, creating a staffing crisis. In this episode, Med-Surg-Nursing Journal Editorial board member Dr. Terry Jones leads a dynamic roundtable discussion with her colleagues from Virginia Commonwealth University Health System, who are creating a new care delivery model for their medical surgical nursing units. Through their efforts, they aim to ease the burden of nurses through incentives and alternative staffing options during this unprecedented time in healthcare. We are pleased to present this important discussion between nurse leaders from the Virginia Commonwealth University Health System and facilitated by Dr. Jones.
So hello, I'm Terry Jones, faculty at the VCU School of Nursing and editorial board member for the Med-Surg-Nursing Journal. It's my pleasure to welcome a team of innovators from Virginia Commonwealth University Health System who are working to pilot a new care delivery model for their Med-Surg nursing units. Team members include Janice Roan, who is the Interim Vice President and Patient Care Services and Interim Chief Nursing Officer, Brett Neville, who is the Interim Associate Vice President of Patient Care Services and Interim Associate Chief Nursing Officer, Dale Wright, who is a clinical nurse specialist and a nurse clinician for professional practice, Veronica Nolden, who is professional practice manager and the Magnet program director, Rachel Weller, who is the nurse clinician of acute care medicine, Laura Reitmeyer, who is the nurse manager of acute care medicine, Heather Fudala, who is the program director for nursing research and innovation, and lastly, but not least of all, is Allison Monpetit, the nursing director of their clinical excellence program. So welcome, everybody. I'm excited to have you here. Now, as I understand it, you are in the middle of an important project related to the care delivery model in your Med-Surg nursing units at VCU Health. Specifically, you are considering a new care delivery model that would include a role for LVNs or LPNs, as they're called in some states. Now, I think this project is very timely and relevant to many Med-Surg nursing units in our country today. So I'd like for you to share a bit of your journey with our audience. So I have a few questions for you that I suspect many in our audience would love to ask. So I'm going to try to be the voice of the audience. So Brett and Janice, if we could start with you, and I would ask if you could provide a bit of background about VCU Health and what prompted you to consider this idea of a new model and bringing LVNs and LPNs back to the acute care environment.
Terry, thank you for having us. This is Janice Roan. I will start off with just a little bit of background about VCU Health. VCU Health is a 3-hospital system that includes VCU Health Community Memorial, VCU Health Tappahannock, and the VCU Medical Center. Our health system employs more than 13,000 team members, and the VCU Medical Center is our urban, academic, tertiary, and quaternary care center, where we are also a level 1 trauma center. Here at the Medical Center, we employ about 3,500 RNs and advanced practice nurses, and like many hospitals across the country, we've experienced significant workforce challenges that have forced us to explore other models of care delivery. I'll turn it over to Dr. Neville to discuss some of our other specific challenges. Brett?
Thanks, Janice. Thank you for having us. So I'd like to take a few minutes and just set the stage on our current nursing workforce situation and challenges that face hospitals, both locally and nationally. This will allow us to have a shared understanding of the context in which we're working and why we felt the need to explore an alternative approach to filling some of the gaps in our workforce needs. So pertaining to the national landscape, there are currently over 182,000 permanent nursing job openings posted. I'll say it again, more than 182,000. That's current as of today. Additionally, there are approximately 40,000 open temporary or agency RN positions, and nearly 80% of those are identified as crisis positions. In our region, more specifically, which includes Virginia, Maryland, District of Columbia, West Virginia, and Delaware, there are more than 2,300 open agency or temporary RN positions. Virginia, in fact, ranks 8th in the highest number of open nursing positions nationwide. Given that information and what we know that nationally our schools of nursing graduate on order of about 55,000 new nurses each year. However, with the number of those openings that we just talked about nationwide, and plus the high rate of turnover that steadily increased throughout the pandemic for a host of reasons, we knew we would need to take a different approach to meeting this need. So Janice and I put our heads together and we asked how we could meet such demands with some degree of urgency. Together, almost simultaneously, we asked each other how we could utilize LPNs in the inpatient setting. Now, we know that just a decade ago, we phased LPNs out of the inpatient care setting at VCU. At the time, there was newer literature and evidence that supported that decision. Also, many organizations, including VCU, were moving towards implementing the 2010 IOM Future of Nursing Report recommendations to increase the percentage of BSN prepared nurses to 80% by 2020, 80% at the bedside by 2020. So that made phasing out of LPNs a priority for many organizations. I'm including that point to say that our decision to try this approach was not made without a great deal of thought, nor has it gone without scrutiny and challenge. However, we know that the same literature that supports that patients cared for by BSN prepared nurses have reduced mortality and morbidity and lower prevalence of failure to rescue. That same literature, that same evidence also suggested that those outcomes were observed when nurses had lower nurse-to-patient ratios, when nurses felt less moral distress and burnout and workload-induced fatigue. Frankly, our RNs were having to take higher patient ratios. They were reporting a higher incidence of distress and burnout, and they had plans to leave VCU or bedside nursing as soon as possible. So we knew we had to act, and we knew that this was the safest approach and that made the most sense at the time. So we reached out to our workforce sourcing partners to see if LPNs were available, and in fact, they were. So I then approached Laura and Rachel to assess their willingness to pilot this work, and as I expected, they were excited to jump right in.
Wow, what a great summary, I think, of the climate that everybody is facing these days and the really tough decisions that you all in administration have to face. So thank you for that and leading us through that very thoughtful decision-making process. So I want to talk a little bit now about your approach to operationalizing things. And as I recall, as you alluded to years ago, we phased out LVNs. And, one of the issues at the time had to do with the delegation skills of RNs, and that we as RNs didn't always have the greatest delegation skills. And that often resulted in less than optimal supervision of LVNs and, quite frankly, patient care technicians and other unlicensed folks that we delegate to. So, Dale and Veronica, how did you approach operationalizing this idea and assessing the feasibility and the availability of resources in your organization to make this time different?
So for this time, not that we didn't do it last time, but we really want to make sure that nurses knew what they could delegate. So we needed to ensure that they had clear guidance on what they could delegate to an LPN. I think this was kind of lost last time because we just had them in the environment. So with them bringing them in this time, we really had the ability to focus on a document or guidance to nurses for what LPNs could do. So that's what Veronica and I looked at. We wanted to look at external resources as well as internal resources. So external resources, we looked at our Board of Nursing in Virginia to see if they had any documents available, from which we found a definition for LPNs, and we also found a decision tree for determining the scope of practice for RNs and LPNs. And then looking out into the literature, we found a survey that was conducted by the National Council of State Boards of Nursing in 2012, which surveyed LPNs and subject matter experts for common practices performed by LPNs. Even though this literature was a little dated, it still helped us see if we were on the right track with this guidance that we're providing our nurses here at VCU. So after we reviewed the external resources, we then looked internally. And this is where I'll pass it off to Veronica so she can explain the resources we looked at internally.
Thank you, Dale. I think that was a really great summary of our external resources. Then we spent a fair bit of time looking internally at policies, procedures, and guidelines that we had put into place and what they said around scope of practice if we were more restrictive than what our external documentation or our Board of Nursing was. And we actually found that often we were more restrictive than what we were seeing in the literature or even in the Board of Nursing. And so we began to evaluate those and see if they needed to be changed or if that was really the scope that we wanted to stick with. For one example of that was we have a 2-nurse skin check on admission. And originally that said 2 RN skin check on admission. And through collaboration with our wound care team, really discovered that the reason it said RN was simply because that was who was practicing inpatient, but not because the skin check could not be performed by an LPN. And so we were able to really expand that. And that's just one example. We also reviewed our job descriptions for any limitations we had within, and it's continued work. Once we looked at all of those things, we collated them, and then we partnered with education and professional development to create a standardized orientation checklist for LPNs. There's 2 sides to this, and one is having the guidance documents for our nurses in the environment, but the other side is to really make sure that our LPNs receive a standard orientation to the acute care setting and that it's supportive. And so we partnered with them. They were incredible, and we were able to get that done. The other thing I just want to mention as Magnet Program Director is we received the question from our other CNOs and the other facilities of, were we worried about magnet status with this change with LPNs in the acute care environment? And we can say that we feel confident that the ANCC is looking at the literature and at the workforce trends and the evolving models of care. And so we believe that by doing this and looking at it from a quality perspective, that will be supported in our magnet designation.
Thank you, Veronica. I think that ties in with what Brett was saying about the literature about the advantage of having baccalaureate nurses is linked to the ratios that they have. And so whatever protective effect that might have, arguably it goes away if the ratios are too high. So I would agree with your approach here, and I think you should feel quite confident. So now to those boots on the ground, hardworking frontline manager, clinical people that now have to carry all these great ideas out. So Rachel and Laura, I was wondering if you could tell us about how you prepared for the pilot implementation on your unit and maybe address specifically how you prepared your existing staff, many of which may never have worked with LVNs before. How did you prepare them for this change?
Sure. Thank you, Terry. I think that we, as a unit, we're in a really unique position within the organization to take this on at this time. Just a very brief history. Our unit was moved during the pandemic to make room for COVID ICU and to really convert some space into what was needed. We moved from a very high-functioning, well-staffed unit. We were kind of split in half, and people chose whether they wanted to stay with and work with the ICU or move into the new-to-us environment. And so with that, we lost over 50% of our staff, not through them leaving the organization, but we just kind of split them in half. And so we were very, very short-staffed over the past year and trying to open a new unit. And so when you talk about that moral distress and the ratios that we were seeing, Rachel and I can attest that it was really disheartening, and our nurses were suffering, and we were feeling that suffering every day along with them. And so when this idea was brought to us, our immediate response was yes, because it's help, it's backup for us. We knew it would look different and that there would be hurdles, but we felt that this was a way to get our staff what they needed, to throw them a line, so to speak. And so I felt really excited about it. Rachel and I were in different positions because she's younger in the profession and at VCU than raised by LPNs. I started before we phased them out, and I didn't, know or really understand the difference early on in my nursing career. These were senior nurses that taught me a lot of things. So I felt really comfortable bringing them back into the environment. And I'll let Rachel kind of speak to her interpretation of things. So she's very much the clinical expert on our unit. And when you say boots on the ground, she is boots on the ground every day. And so she really worked to put together the resources for our staff and get in front of them, which she's done an amazing job with. So I'll let her speak to what she did. And then I think we both have learned some lessons along the way as they got here about communication and what our staff needed from us. So I'll let Rachel speak for a minute.
That sounds great. Thanks, Laura. So the first thing I'll say, speaking just to my experience, as Laura said, I have not been a nurse quite as long as some of these more veteran folks on the call that have a wealth of experience and knowledge. But for me, I think it gave me very fresh eyes to evaluate this consideration. And to me, there wasn't that experiential history of having either a positive or a negative memory of working with LPNs. And so for me, it was a really refreshing alternative to consider. I think one of the other things that I don't think we've touched upon yet is just the financial implications as well. Just as we've been utilizing agency RNs in our environment, they're very costly, especially as many of them are being paid crisis pay. And so looking at utilizing LPNs, it's also a more cost-effective measure than paying agency RNs. And so thanks to the document that Dale and Veronica referenced, they really helped shape kind of the scope of practice, which I think gave me kind of a strong foundation to stand on as I reviewed those documents, reviewed what the Board of Nursing was saying, and really started picking apart what LPNs can do and what can they not do. And so utilizing that document, that was kind of my starting ground. And as we started thinking through this, I started asking questions. What are my nurses going to be asking? What are the questions they're going to be asking? Or what is this going to look like when a new patient rolls on the floor? How is my team going to operationalize that process? So through that, utilizing that document, I also started to create a list of FAQs and started kind of picking the brains of some of my senior nurses as they started wrestling with the idea as well. And so really just started to put out feelers to try to, I think, normalize the possibility for our nurses was really important. There's been so much new things this past year. I think there's almost like a newness fatigue that I see among our staffs. Oh, what's the next thing now? And so really wanted to try to normalize what was happening for one thing and to make sure that we talked through all the questions. And so utilize both the document from Dale and Veronica as well as the FAQs that I drafted and continue to shape and to add to it as my nurses discuss with me. And Lauren, I really set about to try to lay the foundation through our scheduled normal team meetings and daily dialogue. I meet regularly with our new graduate nurses. We protect some time for them. So talking with them, normalizing it. So just tried to make it part of the environment, that this wasn't this unfamiliar thing, but here are the concrete things. I think nurses really love the black and white. And we tried to give them as much black and white as we could to start with. We also made some alterations to our charge document. So to have kind of a list of patients on our running charge handoff sheet that highlight patients that would be very appropriate for an LPN. So highlighting that as well as notating specifically for VCU, LPNs do not administer IV push medications. That is an additional restriction that VCU has put in place. So making sure that we're aware of which patients require that so that we would not be signing patients to those LPNs. So starting from there, we started just kind of circulating the idea. Laura, do you want to talk a little bit about how we went through screening these LPNs and the applicants so that we made sure that they were a good fit for us?
Yes, thank you. That was the next thing I wanted to bring up. And, we were getting these LPNs from our agency partners, and there are various levels of LPNs out there in the agency world. And what we hoped for was LPNs from areas where they had been utilized in the hospitals, and so they were familiar with the acute care environment. What we found is that they were not as plentiful as we thought they would be. And so to really get this off the ground, we had to look at taking some LPNs who maybe had long-term care experience or rehab experience or some remote hospital setting experience, but they had not been in the acute care setting within the last year. And so for both of them, I felt it was really important not to do auto offers and just offer them based on their resume. I really wanted to speak to each nurse and make sure that they were going to be compatible with our unit and culture, and, to kind of tease out their knowledge and background. For instance, someone might be a level 1 because they've had acute care experience in the past year, but then when I would speak to them, it was in a team-based model, not an independent model. So that's very different, and we had to take all of those things into consideration as we brought them on. So what we ended up doing is hiring some that are going to be and that are working independently, and then also some that we decided we probably shouldn't give them their own independent assignment, at least initially, and we put those in a team-based model, which is new to our organization. We toyed briefly with it during the pandemic, but it never really got off the ground. So this is new for everybody. So what we did was chose senior RNs and hopefully RNs who had worked with LPNs in the past to really lead that team-based model. And then we paired them together so that they're with a consistent RN each day so they can really develop that team and work through the nuances of what it's going to look like to do a team-based model, so that as we bring on the next ones, we'll have that kind of cemented. So that's where we are right now with bringing them on. And I think, Rachel can speak to this too, but what we were both surprised about is that we felt we had really communicated and that our staff was 100% on board, that they trusted us in what we were saying about LPNs and bringing them on. And I really had no doubt in my mind that they were going to be very well received. We did meet some resistance in other areas of the hospital, people who, with good reason, believed that this might, as we talked about the evidence of having bachelors at the bedside, there were people who were concerned about bringing them in and the quality. But we didn't expect that from our own staff. There was very little resistance or questions brought up during the communication phase. And I think even having been in this as long as I've been, I forget that, especially when you're on the floor doing this work, and like Rachel said, we're bringing in something new all the time. You don't really think of those questions or have those feelings until it's right in front of you. And so once the first 2 LPNs got here, that's when we started hearing that maybe everyone wasn't fully on board. And so from there, we kind of panicked, like, whoa, what are we going to do? And the next step was to start having individual conversations with people. We felt like after consulting with Veronica and Allison and Dale that maybe having more meetings wasn't the way to go, but that we needed to go out on the floor and talk to people individually and really find out what their feelings are. So I've had several of those conversations, and I have found that there were ideas out there and misconceptions that I had no idea about. One nurse thought that maybe we were bringing LPNs on as a way to save money and not have to pay as much, which in a roundabout way, sure, but no, it's not to cut corners. It's to get the staff the people that they need. And so once I was able to kind of have that conversation with him and explain the ideas behind it, he was like, I'm so glad we had this conversation. And so it really brought to light for me that people are telling themselves their own stories. They're influenced by social media. They're influenced by their peers and other units, not just Rachel and myself. So having those one-on-one conversations has really been helpful in teasing out any barriers that we've had.
One other
Rachel,
thing, I was going to jump in and explain some of the things we've learned. So as much as we've prepared and determined what the scope document shows and what they can and can't do, simple things as far as determining, well, what does it mean to run a secondary, means something very different in a long-term care setting. For a lot of our LPNs, if you run an IV antibiotic secondary, they usually run it on a primary line, and that patient does not have maintenance fluids. So the concept of a piggyback was very new to many of our LPNs. And so you can imagine as they're asking questions, as we would hope, in an area that they want to be better at and make sure they're practicing safely, it alarmed several of our nurses. Why don't you know this? Why don't you know how to hang a piggyback? And so there was definitely this kind of cultural feeling that Laura and I have been working through of normalizing that depending on what type of facility you come from, that knowledge may not necessarily look the same. And so normalizing that and then still creating an open space where these LPNs can ask questions. They can get the training that they need, because the moment they feel like they can't ask questions is the moment we're creating an unsafe scenario. So that was one of the things we've seen. We've also needed to clarify at long-term care facilities, sometimes kind of the care techs really take all of the ADLs and the LPN manages all the meds. Well, here at VCU, we're very collaborative. Everyone shares the load. Everyone helps get patients cleaned up and get bathed. And it's really a team sport. And so identifying that those were blind spots that Laura and I didn't know to ask about and being forthcoming about that and what we have learned has really, I think, opened the door. And I think it's really kind of changed the environment. Now that they're here, they're actually like playing with this idea and experiencing it. A lot of those questions are coming out. And so it's been really cool to see kind of this shift as we've been engaging in these questions. But definitely was a learning curve for me and Laura to really, it's a time-intensive leadership skill. You need to do the one-on-one. And so I think Laura and I learned a lot about that as far as how do we engage people where they're at in the midst of an upcoming EHR transition. Our staff has been through a lot in the last year and a half. And so it was good for us to learn that, but we've also learned a lot from the LPNs, which has been really rewarding.
Wonderful. So many lessons learned. We could talk forever just probably about the pragmatics of it. But I do want to make sure we address one other thing. And Heather and Allison, I'm going to turn to you. One of the things that has impressed me about your team is the desire to do a very thorough evaluation of this change before spreading this new model throughout your organization. So can you share with our audience how you plan to evaluate the model and maybe talk about the metrics that you will use and the stakeholders that you might have engaged to decide these things?
Sure. And thanks, Terry, for having us. Since this is a pilot, our main goal was to cast a really wide net so that we were looking at multiple metrics, things within our performance improvement framework that we're already assessing through our work. Things like patient satisfaction, team member engagement, nursing quality indicators. We also conducted a literature review and consulted with our nurse performance analyst to review the unit's baseline measures. And we know things like falls and pain reassessment data are sensitive to staffing, so we'll certainly be looking closely at those data. But because this is a pilot with a significant change in practice and culture change, as Laura and Rachel described, we knew that we wanted to create space for team members to provide feedback throughout this process. So we created a survey. And Heather, I'll turn it to you to expand on this survey.
Sure. Thank you, Allison. So as all of my colleagues here have previously mentioned, with the worsening nursing shortage, it's really become increasingly difficult to staff our inpatient nursing units at the high levels we know are associated with optimal outcomes for our patients and our nurses. So one of the things that we know happens when nurses lack resources, such as personnel and time, is something that's called implicit rationing of nursing care. So we wanted to capture our registered nurses' perceptions of what types of care were being missed in our environment. So in order to do that, we decided to use the Perceived Implicit Rationing of Nursing Care survey, which we're using to capture some baseline data and then at various points during our pilot. And then as Brett and several others have previously mentioned, our hospital had already undergone some significant cultural change related to phasing out of LPNs in our environment. So the reintroduction of LPNs and team-based nursing presents some pretty significant cultural challenges. And we wanted to capture the current culture on the unit as it relates to team-based nursing and LPNs. And Terry, as you had already mentioned, since delegation is such a crucial component of the team-based nursing model, we designed a survey, to capture our registered nurses' education and experience with delegation, as well as their perceptions related to team-based nursing and delegation. And then finally, we're also using a tool to help us examine and better understand resilience in our bedside nurses, as well as an open-ended question for them to share their feedback and thoughts with us as we move forward during our pilot process.
What a thorough evaluation plan. I'm going to be excited to see what happens with that. And I know our time is coming to an end today, but I really hope that as you progress through this project and as you get your feedback data and you continue to learn lessons, that maybe there'll be an opportunity in the future for us to check back in with you and see how you were doing and what additional lessons that you've learned. But I can't thank you enough for sharing your journey. I suspect that there are so many other Med-Surg units out there experiencing the same kinds of challenges that you are. And I think they'll be really looking to you to share lessons learned in the future. So thank you all for being leaders in this area and being willing to share your story. All right, well, thank you again, everybody, and just wish you all the best with your project.
The Med-Surg-Nursing Journal podcast series is owned and produced by Genetti Publications, Incorporated, all rights reserved. No portion of this podcast may be used without written permission. Participants in today's call are part of an innovative team of nurse leaders at Virginia Commonwealth University in Richmond, Virginia. Janice Roan is the Interim Vice President of Patient Care Services and Interim Chief Nursing Officer. Dr. Brett Neville is the Interim Associate Vice President of Patient Care Services and Interim Associate Chief Nursing Officer. Dale Wright is a clinical nurse specialist and a nurse clinician for professional practice. Veronica Nolden is the Professional Practice Manager and the Magnet Program Director. Rachel Weller is the Nurse Clinician of Acute Care Medicine. Laura Pulliam-Reitmeyer is the Nurse Manager of Acute Care Medicine. Dr. Heather Fudala is the Program Director for Nursing Research and Innovation. Dr. Allison Monpetit is the Nursing Director of the university's Clinical Excellence Probe. Dr. Terry Jones is an Associate Professor at Virginia Commonwealth University in Richmond, Virginia, and is a member of the Med-Surg-Nursing Journal's editorial board. For archived episodes of this podcast and to learn more about Med-Surg-Nursing, visit the journal's website at medsurg-nursing.net. You can also subscribe to the Med-Surg-Nursing Journal podcast on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and everywhere podcasts are found. And remember, as a listener, you can save 50% off 1- and 2-year subscriptions to Med-Surg-Nursing Journal. Simply visit medsurg-nursing.net, click subscribe, and enter promo code MSJSAVE50 to take advantage of this special discount.